Welcome to the International Association for Adolescent Health Pioneers Project. In this series, we have interviewed a range of experts from around the world who have led the way in promoting adolescent health in their countries, regions, or internationally. We wanted to listen to their stories and share their experiences so that these might be applied elsewhere. The members of the IAAH Education Committee were particularly interested in how these pioneers influenced the education and training of healthcare professionals in adolescent health. In the following interview, Risa Turetsky and Abigail Harrison are talking with Dr. Bob Blum, a pioneer in adolescent health in the USA.
Welcome, everyone. My name is Risa Turetsky. I am the Vice President of the North America region and co-chair of the Education Committee for the International Association for Adolescent Health, or IAAH. I'm a nurse practitioner in the United States, and myself and my colleague are going to conduct an interview today with Dr. Bob Blum. My colleague, Dr. Abigail Harrison, has helped to make this whole interview project a reality. Abigail?
Thanks, Lisa. Hi, everyone. It's really an awesome pleasure to be here. I'm an adolescent medicine physician from Jamaica in the Caribbean, and I am a self-acclaimed mentee of Bob Blum. Also a member of the Education Committee for IAAH, and it's just going to be an awesome experience, so stick with us.
Today, Abigail and I are so honored to interview Dr. Robert Blum from the United States. This interview is part of our series highlighting leaders who have developed the field of adolescent health in their country. Dr. Blum is an obvious choice. He is really a founder of adolescent health, not only in the US, but also globally. Dr. Robert Blum is an award-winning scholar and researcher with decades of experience contributing to adolescent health. Bob Blum, as many of us in the field know him, has edited 2 books and has co-authored over 300 journal articles, book chapters, and special reports. He holds a longstanding position as the William H. Gates Senior Professor at the Johns Hopkins Bloomberg School of Public Health. He continues to serve as a consultant to the World Bank, UNICEF, the United Nations Population Fund, and WHO. Dr. Blum has previously served as the director of the Johns Hopkins Urban Health Institute, as president for the Society for Adolescent Health and Medicine, and as a member of the American Board of Paediatrics, among many other roles. As Abigail said to me earlier, we are in the midst of adolescent health royalty. Bob, thank you so much for taking the time to be with me. As committee chair, I am really so grateful. We're doing these interviews to inspire those interested in caring for young people to go even further. But even more so today, we want to share some practical advice and potential pathways for building up the field of adolescent health in areas where it just isn't yet fully developed. Let's go ahead and get started.
Okay, thanks, Risa. So, Bob, what we would really like to know is a little bit about your personal journey, what or maybe who inspired you to take up adolescent health, and just kind of tell us a little bit about some of the challenges you faced and how you overcame those.
So, first of all, it's great to be here. And for the two of you to be doing this for me is both an honor and great fun because, Abby, you and I have a history that go back at least 20 years, if not longer. And I have known Risa since she was a student. So it is really a pleasure. What inspired me to go into adolescent medicine and into adolescent health? The answer is really pretty simple and pretty straightforward. I had a mentor and I had 2 patients that changed my trajectory. Just briefly about the 2 patients. One was a 13-year-old boy who had leukemia. And I should mention, if you cannot tell by my gray hair, that I did not complete my training last year. I completed my training quite a while ago. And I trained in a hospital at the University of Minnesota where the mortality rate for children was very high because a lot of the diseases that they had in the 70s and early 80s were not curable diseases. And such was the case with a boy who was 13. And he had been in and out of the hospital. And he was a baseball player. And it was towards the end of his illness that I was on his care team. I was in training. I was on his care team. And he pleaded with the care team to let him go home for one night. He was fairly weak, but not so extremely weak. And we agreed, and his parents agreed to take him home. He returned 2 days later with an overwhelming infection. He said, what happened? Because his left leg was all scraped up. He said, I went home to play in my Little League baseball game. And I said, you know that there was a huge risk of infection. He said, I knew that there was, and it was a risk I was willing to take because I wanted to live. And he taught me a huge amount what it meant to live with a fatal illness. And the same was true for a 14-year-old girl who had cystic fibrosis, who I became extremely close to. And she too died as a consequence of her illness, but she had an incredible joy of life. And we talked a lot about living and about dying. And those two experiences said to me, this is a field I want to be in. I also had a mentor who was in her early 90s when I met her, Gisela Konopka. And Gisa was sort of the intellectual force that excited me about our field. So that's in not such a small nutshell why and how adolescent medicine for me.
Well, that's definitely some very inspiring situations and experiences. What about the flip side in terms of any challenges you faced in terms of walking the adolescent health journey?
Oh, my goodness. So when I started in the field of adolescent health, it was 1978.
Wow.
And I was at the University of Minnesota. I was a junior faculty member there. And there was no regard, no interest at all among the academic faculty in adolescent health. This was seen as a fraudulent field. It was bogus. People couldn't understand why anyone would choose to go into this. I worked really hard for about 6 months to develop a plan for a special small ward for young people in the hospital. I was really encouraged to do it. And when I presented it to the medical school and hospital leadership, all I can say is it was a source of uproarious laughter. There was not only not taken seriously, it was simply ridiculed. And the chief of surgery said, I think this is a great idea. We should have a separate ward for the spouses of the surgical team. And someone else said, oh, yeah, we should have a special ward for X, Y, and Z. And so this went on, and it was clear from the beginning this was going nowhere. I think that there was really no sense that young people had either special needs or there was value to identified services for them. And it was very much an uphill battle. And I know this is true for many of my international colleagues, that carving out a field like adolescent health in countries where it was just not even considered, it was a very, very challenging situation.
Absolutely. I can attest to that challenge and uphill walk. Thanks so much, Bob. I'm going to turn over to you now, Risa.
Thank you, Abigail. Thanks, Bob. Gosh, I really think about those challenges and some of the experiences I've had also advocating for adolescent health, and I commend you for pushing through it. So can you tell us a little bit more how you really shaped the field of adolescent health in the US? Not only yourself, but you've also been a witness to a lot of the changes that have happened and a team member in them. Can you talk a little bit about the evolution in the US of adolescent health as a field or as a profession?
So in 1977, 78, there was a small cadre of leaders in the field of adolescent health in the United States. People like Felix Heal, Dale Garrell, Dick McKenzie, just three of probably 10 or 15 people. Irish Lit was another. And one of the things that I found being in that field so interesting and so appealing was that it was extremely small. You go to an annual meeting of the Society for Adolescent Health and Medicine at that time, and after 3-4 days, you knew everyone because there were 50 or so people there. It was a very small group. And that group that was the nucleus of the field slowly grew and slowly gained credibility in academic circles. I think there were a set of factors that propelled the field in the United States. One was that there was rising awareness and rising concern about teen pregnancy. And in 1996, maybe, Bill Clinton, in his State of the Union speech that year, said teen pregnancy was of an epidemic proportion. Whether it really was of an epidemic proportion is a different story, but what it did is it increased putting adolescent health on the radar screen. The same is true of rising concern around substance use. And those were sort of the two central issues, sex and drugs, around which the popular awareness of adolescence and adolescent field. The other that was occurring internationally and that has had a significant impact is that child mortality began to decline. Child survival increased through the 80s and 90s. And so you wound up having a growing cohort of young people that wound up being today the largest cohort that in the world. Adolescents today constitute 1/6 of the world's population. Well, it's very hard to ignore those kinds of numbers. I think also the social and political changes that began in the 60s in the United States, but has rippled through the world, and certainly through the Middle East and through Eastern Europe in the 90s, all of this drew increasing attention to young people.
Yeah, that's so true. And we see some of that now also with some of the changes that are happening, and at least there's more attention to it. How did that, what were the steps that you saw happening in the field of adolescent medicine, maybe even, that built on this public awareness to start to really develop this professional field?
I think that one of the things that made the field appealing to practitioners and potential practitioners to go into the field was that it was an amalgam of clinical medicine, clinical nursing, clinical psychology, and social medicine. Today, we talk glibly about the social determinants of health. But in the 1980s, there was no real conceptualization of the social determinants of health. And a number of things, and I'll only use one example, shifted that lens. Tobacco. Tobacco, lung cancer and other cancers was a medical diagnosis, limited treatments, but medical treatments. And research began, and it may have been the first time, began to show that there were behavioral reasons for pulmonary cancers and environmental factors that drove behaviors, and that those behaviors began not at the age of 25 or 30 or 40, but began at the age of 12, 15, 17. And we began to become aware that the social contexts had substantial bearing on disease and illness and health. And I think that that's one of the areas that adolescent health really carved out, was this interface between the biologic and the social environmental factors. And as we became increasingly aware of drivers of ill health, we became increasingly aware of the social factors that drove ill health. And I think that that had a tremendous impact. I think the organizations, both SAM and IAAH, also propelled the field. And I think one of the things that was particularly unique about IAH was that it was much more a local, national entity, not US, but around the world. Practitioners would begin to cluster in interest groups, and they were highly interdisciplinary. In fact and in truth, the United States was a latecomer to really a powerful international lens. But I remember distinctly going to a meeting in Christchurch in New Zealand that I believe Susan Bagshaw had organized. And there were probably 100 people there from 10, 15, 20 different fields and disciplines, from education and nutrition and nursing and health related and sort of beyond health related. And these groups, I mean, certainly Australia, the same was true. These groups really began to mobilize the field. I think that there were some very deliberate strategies also. So using Australia as an example, there was a small group of people influential in the Pediatric Society to begin to lobby for training requirements for physicians to have some knowledge of both the medical needs of adolescents, but also the social and psychological needs. And that evolved into the establishment of the Center for Adolescent Health in Melbourne that continues magnificently to this day. And I use that as an example of work and effort that really individuals began lobbying for in Switzerland. Pierre-Andre Michaud, a family practitioner who then trained in adolescent medicine in Canada, went back, and for, again, 20 years, I would guess, he had no standing at all within his field, and slowly lobbying people, bringing in interested people, began to build a small nucleus. And we've seen this replicated in Portugal with Elena Fonseca, in Chile, with Matilda Madaleno, and people who brought people together that began to form interest groups that began to establish a movement.
That's awesome, Bob. And it's a really good segue into the next question. Because you've kind of shared with us how the individuals can promote training within the workforce, which really is a key feature of what we want from the Education Committee. Can you also share with us, though, what sort of processes perhaps you followed in terms of getting organizations, governmental departments, that sort of thing, to also become a part of this movement? It was really inspiring to hear of those units of one that sort of pushed it, but then, how you expanded that to the broader sense as well.
I think one of the things that expanded it was that the people who were in that first generation, both in the United States and then subsequently around the world, were not average people. And by that, I mean they were willing to pursue a field that simply didn't exist. So that in and of themselves made them unusual. But they were also very politically savvy, extremely politically savvy. So they knew leverage points within their country. They knew how to access ministries. They knew how to access the medical education establishment in their countries. And I would use George Patton as one example from Australia, who really understood not just the field, but the political levers that pushed the field forward. Glenn Bowes was another, David Bennett was a third in Australia, all of whom were very, very politically savvy. And I would multiply that by 20 or 30 people around the world who got training and then went back to their countries. I think the fellowship programs that in the United States were initiated and initially supported by the Maternal and Child Health Bureau also became a magnet for training. And I know that in my experience and the experience of Minnesota, we had probably over a 20-year period, we probably had 30 or 40 physicians, and then subsequently nurses as well, such as Terry Ann Clark from New Zealand, who came and trained and then returned into leadership, academic leadership positions, and some in government leadership positions in their countries. So those were the steps that I saw, that you began to have this network within country, and then people who had connections that were global that really moved that forward.
Awesome.
That's so interesting, Bob. I was thinking about the LEA Fellowship, the Leadership in Education and Adolescent Health fellowship that I know that you helped establish at Minnesota. And so that was interesting what you said. So was it the Maternal Child Health Bureau that established the first fellowships in adolescent health? And is that common for other fellowship and specialty practices for other specialties?
No, it was not common. Again, I think there was this first generation in the States of people who wound up in leadership positions, and some in government, that really lobbied for this. And what I've seen is that to make that kind of impact, it does not require hundreds of people. It requires one or two people who are really persistent, really dedicated, really think this is important, and know how to use the levers of power at a government level, at a university level, at a community level, to really say, this is what we want. And it isn't all at this macro level. Just again, one example is in Sligo, in Ireland. There is a woman who I got to know who came and spent some time with us when I was at Minnesota, who ran a community agency, a community recreational agency for young people. And she said, the people who use our services need healthcare services. And I want to expand and build that out. And over the span of about 4 years, she built a network of people interested in young people. She did not have a health background, but she attracted people with health background to establish what I believe was the first youth clinic in Ireland. And so I use that as an example of the kinds of folks I've seen who've really made a difference in their communities, in their countries.
I think that that must be really encouraging for people who are in this now, that it doesn't have to be this big movement. It can be small. It can start with a few people, either pushing locally or pushing at the university or the government level. And reminds me of an organization I adore, The Door in New York City, where they really started with that small team of people who are interested in providing that health and grew it out. And it's now a huge, beautiful.
Angela Diaz at Sinai. I mean, she was a lone wolf,
right,
and began to attract people. But these are not uncommon stories.
These are the ways that we get there. So as we start to distill this for folks and kind of bring it together, do you have a few practical steps that you would suggest others might take as they're getting started in their country? And you've spoken to many of the ideas. But if you wanted to kind of give some key points that you think are take home, what might those be?
Adolescent health is highly interdisciplinary. To be successful, you have to deeply believe that you don't hold all the knowledge. And that if you don't hold all the knowledge, then you're going to want to attract people who have knowledge and skills from other disciplines that you don't have. And if you don't have that orientation, I think the odds of being successful are much lower. So it is having an interdisciplinary lens. It is being willing to suspend your belief that you have a corner on the knowledge and that you can learn from others. Secondly, that you see your patients as partners. I always said to kids, particularly kids who were arguing with me and really pushing back, I'd say, time out. Let's get real here. I have no power in our relationship. You might think I do, but I have no power. You have all the power, because you're either going to use what I advise or not use it, or use part of it. You will benefit or won't benefit from that, but it's not going to alter my life. And so I need you to be a partner in this. And if you don't think the advice I'm giving you is worth anything, tell me, because I'm prepared to hear what you have to say and try to modify that. Uh, and that was particularly true. I did a lot of work in chronic illness. And that was particularly true working with kids with chronic illness. They controlled the show. The adolescent controls the show, though they don't believe it. And I think we need to see young people as partners. The third is that I am not a big fan of subspecializing adolescent medicine or adolescent health care. I am a big fan of giving it away. I think that there will never be, whether in the United States or in Niger, there will never be enough specialists to treat all the young people that would benefit from it. So providers of all kinds need the lens, need the skills, and bringing folks in from who will never specialize in working with young people, but have some core skills to help them will be advantageous. So to me, pushing for subspecialties is not a way to go.
Abby, I feel like we're on the right track now with all of our policy work and the things that we're doing with IAH, right? Like this is where we're driving. This is really where we're going, is that we want everyone to be in and we want everyone to be aware and ready.
Definitely.
Yeah.
So Bob, what I find so impressive is that 5-6 decades later, you still have that fire burning, and you still have that capacity to inspire. Like I feel like, okay, all is not lost. I'm ready to keep going. But what I would say probably as a last question for me would be, how do you see the vision then if we're going to spread this and give everybody a buy-in? What do you think is the best way for us going forward? What's your vision of adolescent health training and building, human capacity, the resources, that sort of thing, in all countries? Because I can't say specifically, resource poor countries, because I think that the same as you said is so true even for developed countries, where you'll never have enough specialists to see all 1/6 of the population, So give us an idea of how you see us moving forward for the next 5 to 6 decades.
I think one leverage point in many countries, in many health professions, is that you need to be trained and you take some type of qualifying examination. And so to the extent that there are questions in those qualifying exams that ask about adolescent health and development, it compels training in a way that if it weren't part of the examination, simply wouldn't happen on its own. So I think that working with those examination organizations and professional health organizations within one's country is a vehicle to more widely disseminating it. I think that it also is a challenging field as a specialty. And I'll just reflect on this from a US lens. There is a requirement, if you're going to qualify for an adolescent medicine subspecialty, that you take an additional 2 years or 3 years of training to be able to qualify. Well, think about that. In the United States, first of all, you go to university. That's 4 years. Then you go to medical school. That's 4 years. Then you do your basic clinical training. So let's say pediatrics. That's 3 years. So we're now up to 11 years. And you're still not making a salary. And then you do 2 additional years or 3 additional years of training. So you're about 70 years old by the time you finish this. It is a very, very long road. And that is not, I don't think, the pathway to really broadly impacting adolescent health within a country or globally. It is, I think, working with a very diverse set of providers so that they have basic skills. And in low resource countries, and also in high resource settings, the opportunities now to use technologies, both for training and for support for providers, is at a level we never experienced previously. So you can work in the most remote settings and still get really high quality, real-time consultations that you would need to deliver optimal health care. And so the fear that I might have had 10, 20 years ago of doing something I really don't know much about is less today, because I can be backstopped by people who have far more expertise than I do, and feel confident that I am giving patients top of the line care.
Awesome. Very true. It's a shifting, changing world with so many opportunities, even amidst the challenges. Definitely.
Yes.
Definitely. Yeah.
Yes. I see it.
Bob, I want to close up, but is there anything else that you want to say before we close?
I think that for me, the central attraction to this field is that you're working with a cohort of people whose ideas are forming, who are not set in their ways, who can be challenged. They might never let you know that they're paying attention to you, but they're paying attention to you. And I'll close by telling one story. And it was a pretty, for me, very personal story. I have always told the people with whom I've trained, you will never get a thank you. You will never get an acknowledgement from your patients that you have made a difference, but you've made a difference. If you in your lifetime get 1 or 2 or 3, that's a lot. So I left in 2004 I left Minnesota to go to Johns Hopkins. And there was an article, a very nice article, in the Minnesota newspaper that I was leaving and blah, 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 and that I was going to Hopkins. That was neither here nor there. About 3 days after the article appeared, I get a letter. Dear Dr. Blum, I don't know if you're the same Dr. Blum who I saw at such and such a clinic when I was 17 years of age. I'm now 38, and I am married and have 3 kids. And I want to tell you that my encounters with you changed my life. And she went on to say, I saw her twice in a street clinic. One was for maybe 15 minutes, one was for less. And very honestly, I didn't even remember it, but she did. And she said, what you told me opened a door that I never thought was possible. And I decided to live in Minnesota rather than going back to Florida to be with my mother. I lived with my father. And she went on to tell me her life story. Those 2 encounters, one 15 minutes, one less, was transformative. If I didn't leave, if there weren't an article, I never would have known this, but it wouldn't have changed her reality, which was that it had a profound effect. And I think that's the opportunity in adolescent healthcare, that you will never know it, but you will have a profound effect.
Thank you. Bob, you inspired me in 2006 when I was your student, and I'm feeling very inspired and heartwarmed again today because we're talking about not only the opportunities, but the fact that even in our crazy world today, we can still do so much good by bringing this healthcare, this opportunity to our patients. And I loved what you said about it doesn't take 1 million people. It takes a couple of people who are motivated, who care to either start something locally or go to the university leadership or go to the government leadership and make something happen. And I think when you were talking about some of the momentum in society in the past, I was reflecting on how some of that is so true now that I think so many people can really capitalize on that social momentum that's happening now to bring adolescent health to their field. Thank you for talking about interdisciplinary care. As a nurse, I think that's exciting, but we really promote that through IAAH and feel like that is so crucial to our adolescents who you spoke about as being our partners. So thank you so much. You were very humble talking about all these special people who did all these things, but really you are one of those special people who's made things happen for the field and for us. And so thank you so much. We are humbled, Abby and I. You continue to do so much for young people, and thank you for the work that you're doing and for letting us share this interview with the world.
Thank you for this opportunity.